And Drew, take it away.
Great. Well, thanks, Allison. Thanks ACE's Connection for hosting this webinar and all of the A Better Normal series. Um, as Allison said, my name is Drew Factor. I'm an internist in Sacramento, California, home of ACE's Connection. And I thought I'd have a discussion today that's entitled Reimagining Health Care. And the journey to get to this discussion sort of came from my understanding about ACEs, which started about 2 years ago. And some of you know about adverse childhood experiences, I would imagine. Some of you perhaps don't. But when I learned about that, it sort of changed this paradigm of which I saw connecting to my patients, as well as what I sort of envisioned healthcare would be. And that understanding about adverse childhood experiences led me to read widely journals, articles, Wikipedia, books, and then reaching out to some experts in the field to kind of see what they're doing. Three of those experts have agreed to join me in this conversation. And I like the idea of a conversation rather than a slideshow because it's sometimes just boring. And I think if we sort of sit in the presence of experts, we can glean jewels from them. And I have three jewels with me. Anne Watts, Tracy Gaudet, and Liza Guroff. And in a minute, I'll just read their bio so you can kind of understand where they're coming from. I want to encourage you guys to think of your own questions. As they might pop up, if you want to unmute yourself and ask the questions, feel free to. If you'd rather just put it in the chat, feel free to do that. And I really want you to think about what you might hear from the discussion or add to the discussion, and all of us sort of take home something, because I think if we're going to reimagine healthcare, we all need to do it. We all need to be a part in it. And because we can't expect for someone else to do the work. We're all part of the community. So one of our guests is Anne Watts. I'm going to read from this bio. Anne Watts, if you raise your hand. She's a professional, certified executive and team leadership coach, a trauma-informed facilitator, and a subject matter expert on homelessness. And I actually met Anne through a colleague who is very instrumental in addressing homelessness issues here in Sacramento. With over 35 years nonprofit and educational organizational senior management experience, she specializes in program development, cross-sector collaboration, and implementing trauma-informed systems of care. Her expertise includes creating and developing residential supported housing programs for youth, family, and dual diagnosed previously homeless individuals, and currently is the California Housing Program Manager with a large national healthcare organization. She's a requested conference speaker and workshop presenter on subsequent trauma and stress and its effect on adults, youth, children, families, and organizational systems of care. And she's committed, as I well know from the several times we've talked and met, that she's committed to helping those who undergo traumatic, stressful experiences to find healthy, healing perceptions of themselves, build resilience, and strengthen and renew their relationships. So welcome, Anne. Our next guest is Liza Guroff, who is, where is she on the grid? Liza is trained as a licensed clinical marriage and family therapist. She currently serves as the director of Traumainformed services for the National Council for Behavioral Health in Washington, D.C., and has more than 25 years of experience in behavioral health field, both as a clinician and administrator, and has worked in a range of clinical settings from treatment programs to outpatient mental health, private practice, and community-based adult services as well as a variety of residential settings. Prior to joining the National Council, she served as the COO of a large mental health provider in Montgomery County, Maryland, where she oversaw and directed implementation of trauma-informed care practices across the entire agency. So welcome, Liza. I don't like this grid. I'm trying to find people, but she's somewhere there.
Yeah, it's weird. Normally, if I make everyone a co-host who's on the panel, they all arrive on top. So I don't know,
There we
Lisa.
go.
I don't know why it's picking you bottom, second row.
Okay, good. Our third speaker, our third guest is Tracy Gaudet. Interesting, I met Tracy because she was one of the speakers at the Academy of Integrative Medicine Conference in San Diego a year ago. And I tracked her down and finally was able to speak. Amazing woman. She's board certified in OBGYN. And since August of last year, she has served as the executive director for the Whole Health Institute in Bentonville, Arkansas, with the mission of making whole health accessible to all people in all communities. Dr. Gaudet previously was the executive director of the Veterans Health Administration's National Office of Patient-Centered Care and Cultural Transformation. That office is charged with leading the VA's transformation to whole health, which is an approach to healthcare that empowers and equips people to take care of their health and live their life to the fullest. Previously to her current position at Whole Health and the VA, she served as executive director of the Duke Integrative Medicine Department at Duke University, which under her leadership created a state-of-the-art healthcare facility dedicated to the transformation of medicine through the exploration, demonstration, and research of new models of patient-centered care. And prior to her work at Duke, she was a founding executive director of the University of Arizona's program in integrative medicine. She also co-founded the Consortium of Academic Health Centers for Integrative Medicine. She's a recognized leader in the transformation of healthcare and has spoken nationally. She was featured on PBS in a special entitled The New Medicine. She was named by Shape magazine as one of the 11 women who shaped the world. In 2011, you're blushing, Tracy. In 2011, she was recognized as one of the top 25 women in healthcare by Modern Healthcare. And in 2013, she was featured in Fortune magazine as a game changer. She's also the author of two books, one called Consciously Female, a book about integrative medicine and women's health, and the book Body, Soul, and Baby. So illustrious group here. As I started to think about leading off this talk, I wanted to sort of set the stage. And as I was reading Tracy through Whole Health Institute's website, I came across this quote, which I think summarizes what I wanted to say, but I think you probably said it better. So I'll read that and then we'll start with the discussion. There's no question our reactive health system is ailing. Americans spend more on healthcare per person than any other nation in the world, but is ranked 12th in life expectancy. I actually did some research. I found it research from 2014, I believe it said is 34th in life expectancy, just past Lebanon, if you can believe that. Mm-hmm. And 28th in the top 50 of the United Nations list of healthiest countries, 28th. So Whole Health Institute says, together we can change this narrative, and that's why the Whole Health Institute is working to propel a collaborative movement to radically redesign the systems impacting health and well-being and strengthen the power of communities. So maybe we can start off with that. I guess, Tracy, maybe you could sort of speak to what is whole health? How is the Whole Health Institute perhaps different from other models of care? And, could this be a blueprint for how other healthcare industries around the country and if not around the world address healthcare?
Yeah, sure. And I've been having audio problems. So you guys are hearing me okay?
Perfect.
Yes. Okay, good. It's been a stressful day. I don't know what's going on. Something strange. So thank you, Drew, and thanks to everybody for joining. It's so great to be a part of this dialogue. So yeah, I'll try to be brief so we can learn from each other. But the way that we're defining whole health, which we really kind of coined the phrase in the VA work, because we found when we were talking about integrated medicine, people tended to think, oh, it's about acupuncture or these approaches that are important, but didn't get the whole paradigm shift. So the concept of whole health, which is fairly intuitive, but the concept is that whole health both empowers and equips people, and those are things that the current health system doesn't do well at all, either one, empowering people or equipping people to actually take charge of their own health and their well-being so that they can live their life to the fullest. And I think that's an interesting interface, with ACEs, which is if the intention of healthcare were to really flip and say, yes, we're going to manage diseases, et cetera, but the purpose of health, if the purpose of health and health systems were to actually partner with people to help them rediscover a sense of meaning and purpose in their life, and then come in behind that and help them with skills and support that they needed to take on their health and well-being so they could live their fullest life, that's a big paradigm shift. I would say clinical care is still a part of that. We need clinical care and we need disease care, but it's no longer at the center of healthcare, if that's the model. And so we're really trying to drive that change in a big way. From my perspective, the Institute is just a catalyst. So there are so many people, like the people on this call, that are already doing this work and trying to drive change from all of these different aspects. I think what the Institute can do is help to bring those forces and the work already underway together. It's pretty siloed right now. I think phenomenal work is happening, but it's pretty siloed. And if we're going to flip the whole system, we have to integrate and synergize across those things. Just like a really quick example, even if we create health systems that are based in this model, then we also have to train people differently so they know how to function in those. We also need to change how we finance it so that it's, incentivized and reimbursed, et cetera. So, we have a lot of work to do. The good news is so much work has been going on for so long. Hopefully now we can catalyze it across all the different systems.
Wonderful, Tracy. As I think about and Liza's work, it's really what we talk about in trauma and care in terms of how we relate to patients. And I'm wondering if Anne or Liza can if we can just sort of bring some lexicon into this. Anne, would you give a stab at defining trauma-informed care and how that may relate to how you relate to patients and how you kind of see it?
Sure, I can do that. Trauma.
Reimagining health care.
So trauma-informed care, especially in an organizational level, it helps those around you in the culture. I'm sorry, I talk with my hands to acknowledge the role trauma plays in someone's life and every part of what's going on with them. And I've worked in organizations where we look, we work with those who are experiencing homelessness or at risk of homelessness and people who've lived on the street. And for years, and I've been doing this work for years, not acknowledging the traumas that are inherent in living on the street, but also not recognizing the traumas that those who serve those who are living on the street are experiencing traumas are undergoing as well. So it's a process, and it's a really tough process because we're not used to thinking that way. We're used to, from my experience, of, okay, it's your job, you do this and deal with it. Not acknowledging the traumas that I or my staff may experience in working with folks, which in turn, it doesn't acknowledge those, folks who are experiencing it. It's not acknowledging the trauma or the pain that they, have and been undergoing. So that's the focus of the work that I have done and I continue to do in my position now and also as a coach of looking at folks and helping them to understand, you know, the traumas that they've experienced and not deny it, but to walk through it. And that's pretty much what we've talked about, Drew. You know, that's been my focus of doing that. But it changes trauma-informed care. Understanding it, or trauma-informed systems of care, help you to think about and respond to those who've experienced trauma differently. So it brings an awareness, and that's what, you know, I do as a coach as well. I bring an awareness and help you think differently and give you some questions to ponder, some things to think about it. How would you do things differently in the work that you do? So if that answers your question.
Yeah, and you know, it specifically, I think, ties back to Tracy and the work of Whole Health Institute, which is really allowing patients to gain their power, to gain their role in taking care of their health, and not just listen to their doctors and saying, you need to do this, you need to do that. It really changes the dynamic. Yeah. I'm just curious, Tracy, and I'll get to you, Liza, in a second. Have you heard the term trauma-informed care? Because I don't know that you and I have specifically talked about that.
You know, it's so great. I'm learning from being on this call, and Ane, I love your work. So I know exactly what you're talking about, but I don't know. I have not learned of that term or this field. So, but I mean, everything you're saying resonates. And I'll just give a really quick example that just came right into my mind, Drew, that I think illustrates this. And Ane, you can tell me if I've got it right or wrong or somewhere in the middle. But I was talking to one of the facility directors when I was still in the VA. I think he was in the Dallas VA. It doesn't matter. But he talked about how, you know, in the medical paradigm, that, you know, we don't want people to smoke, or we want people to lose weight, yada, 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 for good reasons. I mean, for good reasons, right? Yes, that would improve your health. And he told a story of this, and he's a little guy, this facility director, a relatively small man. And he talked about this huge veteran, angry, comes storming into his office as the director, slams his fist down on the table and says, I swear to God, if one more of your employees tells me to stop smoking, I will never come back. And he said, they do not understand that sometimes that cigarette is the only thing between me and that gun to my head. And to me, it was like this illustration, right, of the myth that where we don't understand people's lives and their burdens and their trauma and their sorrows, even though we're well-intended, it's not only doesn't work, but it can actually cause tremendous harm. So Ane, I don't know if that resonates.
Absolutely. And this is one of the things that I've uncovered in doing this work too, that how can you tell somebody to stop what we consider overeating, smoking, drinking alcohol, or indulging in any type of drugs? These are self-soothing, you know, methods that people have to soothe their trauma. And you've got to look at it differently. It changes, and being informed about trauma changes how you think and how you view folks, you know, and how you work with people. You start to look at, I love what you're doing with the whole person, you know, kind of like whole person care, and looking at the whole person, not just a slim sliver of what you think is going on. It's not, you may miss an opportunity to help. I get really excited about this topic, especially in this forum talking about, Drew knows that because I talk with my hands. But, you know, you will miss the opportunity to really be effective with that person and for that person to be effective for themselves and uncovering some of the traumas and some of the things. And the shame, too. There's a lot of shame associated with this, too. And folks don't, and I found that with homelessness. Folks don't want to acknowledge that's what's going on. And they don't want to acknowledge that, you know, they're experiencing homeless, they're living on the street, and they're in this condition. They alienate themselves from their families, you know, due to these issues too. So I can keep going on, but I won't do that, Drew. I will turn it back over to you. But thank you, Tracy, for that.
Well, you said an important word is change. And, you know, when we attempt to get someone to stop smoking, we're expecting a change. I'm trying to have a nice sequitur here. You know, as I was looking, when I was learning about trauma-informed care, I looked to leaders and organizations across the country who are doing trauma-informed care. I looked at SAMHSA, and I'm going to forget the acronym, but then I found about the National Council of Behavioral Health, and I reached out to Liza Guroff. And so, Liza, I'm wondering if you can, so the National Council is doing amazing stuff there, and I wish their work were more spread out. I wish more people knew about their work. But I'm wondering, Liza, if you could talk a bit about the change package and what the National Council, like when you think of the National Council of Behavioral Health, you think of mental health. You don't think of this. So I'd be curious, some people may know about the change package, but I'd like you to talk a bit about that and what you've done.
Sure.
Yeah.
Sure. So I will use Tracy's disclaimer too. My internet is, I don't know doing what today. So I might disappear, but you'll still hear me and I can hear you guys. The fun of Friday, I don't know. So what I would say is, from what Tracy and Nene were talking about, I would take it one step further back in the lens and broadening it. I have yet to meet a human who has not been traumatized. And I think we do a huge disservice by trying to specialize, focus, put in a box a certain special type of human. And so from our perspective, any human you interact with, we should be interacting in a trauma-informed, resilience-oriented way. And you know, we can't talk about trauma without talking about resilience. They go hand in hand, and explain why we all experience life in a different way, right? So important that we kind of take that lens further back from my perspective and pick a human and treat them in that way, as opposed to specializing populations or treatments. And you know, that difference of a trauma-specific treatment versus a trauma-informed, resilience-oriented lens. So we have at the National Council been working for over 10 years with organizations, not just in behavioral health, but I work with property managers of buildings and school systems, and you know, pick someone who interacts with a human and we work with them. So in terms of really changing the way that we look at our mission and changing the way that we interact with our budgets, our job descriptions, the staff, everything from, you know, our funders. And so at the National Council, we partnered and rolled out about a year ago with Kaiser, with the Kaiser Foundation, a change package that Drew's talking about that was focused on helping primary care offices translate the SAMHSA principles, which are great principles and are so important. But I have definitely found as a provider, it's like the theory sounds great. How do I make that? Like, how do I make that really happen? And so the change packages can help. Our consulting, the work that we do is all in that translation to implementation. What would a trauma-informed supervision note look like? What would a policy or a job description for my agency look like? How do I put it into my budget and my strategic plan? Because it isn't a one and done training, right? We are philosophically changing the way we see our world and our place in that world, and how we then would organize our supervision or our, you know, like I said, any interaction with any human. So the people who deliver your mail or your food, you know, up to the CEO or presidents of organizations.
Yeah, so what I hear you say, Liza, is, you know, what it comes down to, it's about relationships.
Absolutely.
It comes down to relationships. And I think what's the most difficult thing is it's easy, in a sense, to change a relationship between myself and you or Anne or Tracy or anyone on the call. It's a lot more difficult to change a relationship to an institution or a system which seems sort of stuck in place. And I remember about a year ago, there was a physician who came into the group, Sutter Medical Group, where I worked, who talked about physician burnout and physician suicide. And he said, you know, it's not about being a physician. It's about being in the environment that creates us, that changes us. And, we're living in an environment in the world around us, which is so triggering all the time. So I guess one question I have is, realizing that it's at its base, a relationship, okay? How do we start changing institutions? How do we start changing systems? Because we can do our best, but if we walk into a system that is traumatized, that system is likely to traumatize me or traumatize other people. I don't know, anyone can chime in here.
Well, Drew, what I would say is from the system perspective and an organizational perspective, it's still made up of people, right? There is no system you can touch. It is the compilation of relationships and systems. And so a lot of this work to change an organizational culture has to come from the buy-in of the leadership. Because as much as we want to do underneath, right, if our leaders are not acting in that way, they will continue those old traditions. And there's safety in that, right? I know what to expect, even if it's traumatizing. Change is hard. Institutionalizing change is hard, very doable. But I can tell you, going into the pandemic, the organizations that we had been working with and had built and really invested on the leadership side in relationship with those that they serve in a leadership position are faring much better. And we're really in a good place to walk into crisis because it's all relationship. Trauma occurs in relationship. Trauma is healed in relationship. We are social creatures. We are not isolative. So, we thrive in those relationships, and the better our systems and the people in our systems, us, right? Those humans in there take a different stance, then we all thrive in those systems. But it comes from fear, I think, to not do that work.
Elizabeth, I'd like to add on to that too, that, you talk about it starts at the leadership level. That includes the board level, your board of directors, writing it into the mission, and the vision statement, so you start to change the culture there, because that's where it all starts. And then you start to build in, the resources and the supports to be able to make this work. And then as you move down the line, you have champions for this throughout your organization to be able to continually talk about trauma-informed care or trauma, instilling trauma-informed systems of care throughout the organizations. And that means supervisors, and that means managers. And that it's, as you said, it's all the way down the line. I've worked with organizations too where, we pulled in the janitorial staff, the security staff to be able to, have them informed of, and because folks interact with them all the time, in some of these programs that I've worked in. So you embrace everybody. It's that whole, I guess, systems, approach to instilling trauma-informed systems of care.
I would completely agree. And, I've had people ask me, how do I know an organization is trauma-informed? And then I say, pick up the phone and call. And if whoever randomly answers that call cannot tell you that they're trauma-informed, then they're not. Because you're absolutely right. It's the security guards and any human in that system needs to be on that path.
Mm-hmm. And, I'd just like to say one more thing. I'm sorry, Tracy, that even the environment, it's exciting. The environment that folks walk into needs to be, to reflect the trauma-sensitive, and look to it as well. And there are things that could be done about that. So, sorry, Tracy, on to you.
No. I was just going to, this is a fun dialogue. I was just going to add some reflections around, you guys were both talking about, and I completely agree, changing culture. And I wanted to just say, because I've got obsessed since I was in such a huge system in the VA, massive, crazy big system and not always very functional and supposed to be changing the culture. I got really obsessed with, okay, how do you actually practically do that? And so I thought maybe just sharing a little reflection on that, because I think it's as pertinent to those of us who are trying to change big systems as it is on the individual level. You know, it's as is above, so is below. So I think the thing that, that I really found useful is to think about that behavior is usually driven by, and again, whether it's a system or an individual, by both experience and incentives. So what I mean by that is, like, if you're going to try to get buy-in from the leadership or the janitorial staff or whatever, that unless they have a personal experience that resonates with them and touches them, it's not likely to create a passion in them to move their hands like Ane or really drive change, right? So there has to be an experiential piece that is significant for them. And then that's not enough, right? Because then they'll be motivated, but if the incentives in where they live or work are not aligned with that change, they're still going to fail, right? And so I think that for me, I just wanted to share because I think that can help operationalize this for people. Like if you're trying to drive change, whether again, big system, small system, individual, for me, it's always been very helpful to think, how do we provide an experience so that it's, you know, intrinsically motivated and at the same time work to align the incentives so that that behavior and that change is sustainable. And that's sometimes a really helpful way to think about how do you move forward? You know, culture is a big amorphous term that sounds like, well, I don't know how to do that. But I think that's one strategy that can help.
Yeah, and I'd say, Tracy, we're all professionals, right? And so we're trained in building our widgets, right? Or doing our field. And there is a whole field on change management and how to change an organizational culture with sustainability in mind. And so the reason that I actually joined the National Council a couple of years ago was I was on that side of trying to change an organizational culture, having my clinical skills, understanding, communicating, providing, and getting people excited, but then what? We really spend a minimum of a year with organizations, with teams, plotting through that implementation piece of where the rubber hits the road. And as Anae's saying, right, who needs to be at the table? And how do I change a job description? And what color paint do I pick to be more trauma-informed? And, why is it important that we all sit in the same chair and we're all comfortable? Get rid of the signs that say special people only over here and other people over here, because it isn't just one training. It's not only getting people excited and engaged, exactly what you're talking about, but then getting it into our blood so that we eventually say, well, that's just the way we do things here. Why wouldn't we, have clients interviewing our doctors and picking what doctors work at our agency because who's impacted by the doctors, why wouldn't they be approving our strategic plan? Why wouldn't they be, it is such a mind shift that not only do we have to get that momentum, but then we have to put it into practice. And like you said, helping everyone understand that it impacts all of us. When we were in person, I would ask in the room when we started, where were you when the second plane hit? And that brings it exactly what you're talking about, that recognition that we can all touch in ourselves that place of pain, that place of concern, of anxiety, understanding our human fight, flight, and freeze response and when it gets triggered. And when we go there and just be human, then we go, oh yeah, we can't keep doing this. We can't keep doing this to ourselves and to each other.
Mm-hmm. Yeah, one thing I wanted to just point out, and maybe you guys already know this, but I oftentimes think that the term trauma-informed can be traumatizing, right? It's traumatizing to talk about trauma. And, maybe there's a better term out there, but it certainly, those of us who've used to the term are familiar with what it means. And I just wanted to give you a brief story. I've given talks about ACEs and trauma-informed care to a lot of the groups within my medical group where I worked. But one particular conversation that I had was with the staff. And I had 30 minutes to talk about adverse childhood experiences in trauma-informed care. And I gave the story of one of the nurses who, on their way home from work one day, witnessed a car accident, got out of her car and did CPR on a young boy, 6 years old. And the rest of the family was standing around her waiting to see what would happen. And she realized in that moment that the boy had already passed away, but she was continuing to do CPR to give hope to the family as the EMTs were arriving. She was really shooken up about this, obviously. And I saw her pass my office door as she came in that day. And I said, "How's it going?" And she said, "I'm really shook up. And I really don't want to hear, or I don't want to hear. I'm really afraid of all of the people reaching out to me to find out how I'm doing." And I realized in that moment, if she didn't feel in a safe place where she could be nurtured and heard or left alone, she was not in a trauma-informed care setting, despite the fact that she was all around surrounding with friends. So I use that as an example with the medical staff. They loved this nurse, Lori, but she didn't feel safe. And as I told that story, people were starting to think about what it meant to be trauma-informed, to, how to approach someone, knowing that, like, "How's it going?" may not be the best approach to someone who just witnessed a child's death. But more so than that was the creativity that started after that. When people started to think about it, they started to think about everything differently. I had a medical assistant come to me and say, "Dr. Factor, I think maybe I should change how I say, 'How are you?' to a patient, because 'how are you?' may be triggering, like, 'How am I? I've got cancer. What do you mean, how am I?'" And she just started to think about things in a different way. And I think when we understand it, whether you call it trauma-informed care or you call it, human relationships, you start being creative. And I think that's what happens in a trauma-informed care institution, is you actually become creative about looking for things that aren't done in a trauma-informed care way without someone telling you to do things. And I think my hope is that, if everyone is trauma-informed, or however we want to term it, we can start being creative about creating a different culture. And it's really about creating a different culture.
Yeah, and Drew, so the magic questions, right, are what happened to you and what's strong with you, as opposed to our deficit model or our shorthand, right? I've seen plenty of Americans walk down the street and say, "Hi, how are you?" and keep walking, right? So the question is an irrelevant question in our society now, because no one really is asking you, right? It's just a greeting. And so, you want to shock someone, say, "I'm not really that great right now." No one knows how to respond, right? Because they're already 5 city blocks away from you by the time you get that out. But it is that transformation of asking what's happened to people. Trauma happens to you. It's not something we invite in, right? It's not something that we go out and seek, but happens to us. And that allows for people to share their stories and to talk about their experience in a much more inviting way. And that strength, as Anae said, what we might see for whatever reason in our own stifled lens is a problem for you might actually be your biggest strength. And so recognizing people are doing the best they can, all humans, that means our staff too, are doing the best they can with what they have. And that we really need to look at skill building and misplaced coping mechanisms, as opposed to labeling and blaming and shaming, right? Or even compartmentalizing, what Tracy's work is, right? Moving to understanding the whole person, not the hole in the person.
This is starting to happen also in schools. Before the pandemic, of course, now it's different, of course, but there's a movement to be to have more of a trauma sensitive approach to children who are, say, give an example of maybe acting out, or the behavior has changed. Instead of suspending, these young folks, just outright, you're not complying, you're not fitting into that box, but really trying to understand what is going on. Hey, what happened to you this morning? How was your morning? Can we talk about it? It's a lot of things that, to take into consideration, but a trauma-informed care, our trauma systems of care, does change how you think and really opens up the mind to inquiring and really being sensitive and compassionate. I think that's the word to use too, that being compassionate with others, and particular right now, this is happening more and more with everybody. We're in this collective trauma state right now. That's the way I see it. And bringing out the compassion with each other to really just open up and listen. And I, as a coach, I'm trained to listen, but I do that anyway. But listen, and not react, and not have it in your head of how can I fix this? Because it's not fixable from your perspective. It's not up to you to fix that. So I just wanted to add that.
Yeah, it's, Dr. Perry's work around all of this, right? Dr. Bruce Perry, and understanding that bottom up for humans, for kids, for adults, and creating those safe spaces so that we can process information beyond fight, flight, or freeze is so important. Right now we talk a lot about moral injury, and just that, as you said, that complex trauma state that we are all sitting in. We are bathed in cortisol and adrenaline, whether you realize it or not, because of everything that's going on around us. And so the importance of those breaks, the importance of taking care of yourself. You're the only you we have, and your you is the one that's going to be with you afterwards. So if you don't take care of your mind and body now, it will not function a year from now, post-pandemic, when we're in whatever our better normal is. So important that we understand how the body works, right? How we respond to complex trauma, and that we have outlets and safe places to really address that and to take care of ourselves.
Yeah, I sometimes notice how I react to things. I won't mention names, my wife, it's a natural reaction to blame the other person for the way they acted. But one pearl that I've learned is it's not about the other person. They've got their issues. We all have issues, but it's about how that resonated with me. Why did that person trigger me? And it's my job, as you were saying, Liza, to look inside to me as to why I was triggered. Because if I'm triggered, I go to see someone else, they're going to be triggered just from me being anxious. And it's this big pool of people being triggered and triggering other people unintentionally sometimes. So, going back to sort of doing the work, and it's sort of outside of this discussion about how to do that, but we all need to be, compassionate with other people, but also compassionate with ourselves and how we react.
Absolutely.
We have about 10 minutes left. I don't know if there are people who'd like to unmute themselves if they have any particular questions. I don't know if Allison.
Yeah, we'll just call on folks who put something in the chat. So maybe we want to hear from Jerry. And so I'll invite you to unmute yourself.
Hi, everyone. Jerry Rogan, former family practice doctor for 18 years in Walnut Creek, California. So we had a holistic practice where we saw patients 84 hours a week, open Saturdays, Sundays, urgent care, emergencies. And part of that was holistic care. And one of my mentors, Marion Stewart, helped me figure out a way to elicit a patient's past issues or current issues related to emotional issues within a 15-minute visit. So one patient had a great deal of anxiety, and she came in with really fatigue, And over discussions, turned out that I was able to find out that she was getting divorced and that she blamed herself for the divorce because her husband was having an affair with the next door neighbor. And that's why she divorced him. And it turned out that the next door neighbor was a man. So she was questioning her femininity and thought that maybe she wasn't a adequate female, and drove her husband to become gay. And that was the basis that then brought out our discussion about her femininity. And I asked her how she was handling it, and she had sex with her son's best friend to validate her sexuality. That's how she handled it. So we had a discussion about that. But the point for this group is that using the BATE technique that Marion Stewart teaches in her book, The 15-Minute Hour, is a good way for primary care doctors to help get a better handle on what's bothering a patient when the patient has a condition in the office that seems to have an emotional basis, such as headaches, back pain, depression, anxiety, and so that's my tip for today. I put the name of the book in the chat box, but I thought it was the best book I ever read in how a primary care doctor from a practical perspective can help understand some of the underlying issues with patients.
Thank you for sharing.
Jerry, are you familiar with Gabor Mate's book as well? Dr.
No.
Gabor Mate out of Canada. He wrote When the Body Says No. Last name is spelled M-A-T-E. First name is Gabor, G-A-B-O-R. He also wrote In the Realm of the Hungry Ghost. But When the Body Says No is a great book for physicians in terms of linking the somatic stuff that you're seeing with trauma, both current and past.
I see. So Marion Stewart's book was mostly to help doctors figure out how to find out what's going on with the patient. And then it sounds like Gabor's book might be a way of learning what to do next. Is that true?
Absolutely.
All
I'll
right.
let you borrow my book, Jerry.
Pardon me?
I'll let you borrow my book. Yeah.
Thank you.
Yeah.
So, okay. We can, there's a lot of comments, so let me just see if I'm missing kind of anyone. We can call on Alex. Are you still here? Yeah. Okay. You have a question.
Yeah, hi. I was curious, I think with clinicians and people in practice, it's not difficult to make this argument of like why this is important and how to start to think about their practice changing. But when you get to people who are like further removed from practice, it gets harder to explain the value and how to get people sort of on board with, like you're talking about large scale systematic change to how their organization works. So I was wondering how any of the panelists have started with some of the folks who maybe don't actually even have foundation or background in healthcare or in social services. How do you sort of get them to understand this?
Well, I could dive in if that works. Okay. Just from my perspective, Alex, I think one sweet spot where we were talking about incentives being aligned with the change we want to see, one place where incentives are pretty much aligned, even if there's not a lot of insight, are actually through employers, because they want to lower the cost of healthcare and they want productive employees. So they actually have the right incentives. Now, they may not have the insights into the things we're talking about, but at least they want to address the health and well-being of their employees. So, and as you were already saying, and Jerry was saying, so many chronic conditions and mental health, and all of the conditions, no matter what we are prone to, are going to get exacerbated when trauma is exacerbated and stress is exacerbated, et cetera. So I think there's a big piece of this approach. One of the things we developed more as we were trying to do this newer approach and more holistic approach is realizing that we can't just pile it onto the clinician. I mean, and even only doing it in the healthcare environment is not where people spend their lives. So a big piece of, and we're, you know, if you're interested, that whole health organization that we're standing up it will be delivering training and at no cost, et cetera. We're just standing ourselves up, but you can certainly reach out to us so we keep you informed. But a big piece of the whole health model is training peers. So training peers to do a program. One of the things that we do is called Taking Charge of My Life and Health. And so it doesn't involve the clinicians up front. Hopefully it integrates with clinicians, but you can get like-minded peers from the community to lead these groups, and it can be unbelievably transformational. And employers are often incentivized to say, yeah, like, let's get a couple volunteers to do that and start offering that in our community or in our company, because the incentives are aligned. So to your point, not just trying to drive it through healthcare providers alone.
Right.
And yeah, I would just add data around the quadruple aim. And that when you look at the quadruple aim, which is the healthcare like go-to, that the data behind trauma-informed care is going to address all of those issues, like Tracy was saying, right? It addresses the provider group, it addresses the outcomes with clients, it addresses fiscal costs. So we see a reduction in, you know, all of those measures across the board when organizations become trauma-informed. So it's speaking to what their pain points are, right? And helping them connect the dots with how this practice and organizational culture actually helps leaders address whatever their, you know, need is, or their pain points or, you know, areas of concern are.
But they have to know to ask, right? You know, right? They have to know to ask. And I think a lot of organizations may be, and I'm not an expert, but maybe sort of stuck in this old model of, let's see more patients, let's see patients quicker, let's do more procedures, you know, and that's the way we're going to sustain ourselves. They may not necessarily know the model that, you know, that you guys are working on or are doing. So I think,
well, Andrew, that's the system it's set up to be, right? Right now, a lot of people are in these fee-for-service systems. The sicker you are, the more I see you, the better, you know, the more we get paid, and then we can be there to help more people. And so it's across the board, you know, whether it's on the policy level or the CMS level, down to the boards and, you know, everyone else.
And I want to add to really quickly that it's making people sicker. You know, you have folks that I've worked with also that they're not going to go to doctors, you know, particularly people of color, because I don't like how they interact with me. I don't like how they look at me. I don't like how they're treating me. They won't answer my questions. And there's a lot of, and I'll just say this, I know we have short on time, but there's a lot of implicit bias, you know, and when there's rush situations, when there's a lot of stress in an environment, when you're under these deadlines and timelines to see 20 people in an hour, I'm not sure. I'm exaggerating, of course, but I could be right. I'm not sure. But that brings on a lot. Okay, 5 an hour. It brings on a lot more of the stress, and it brings on a lot of the biases. And people sometimes don't even realize they're doing it. So a lot more work has to be done, and a lot more conversations like this need to be had to really put this out there.
Well, and the good news is we know a lot of what will work. We just have not implemented it in the right places.
That's right.
and I know we're out of time. I just want to leave all the participants with two things that I'd like you to consider taking home with you. And that is to do our own work wherever we are, whether it's in our relationship with our spouse, our child, our neighbor, or our healthcare provider. And if the next time you're at your healthcare provider, ask him or her, have you heard of the term trauma-informed care? Have you heard of adverse childhood experience? If you have a diagnosis of depression, go home and Google ACEs and depression and be ready to give that to your doctor so that you can inform them what you know, because it's important for us to educate our communities, because it's not going to be from a top-down approach for most of, outside of the Whole Health Institute and other organizations that Liza, Guroff, and people at the council deal with. It's going to be a bottom-up approach. And so we all need to do our part.
All right. Well, yeah, we will start wrapping up. Thank you all so much for being here. Drew, maybe you want to go around and have everyone just say a couple concluding thoughts.
Well, those were my concluding thoughts. Ane, do you have anything to say?
I just like with the support what you're saying, Drew, and start the conversations. This is what I tell folks: start the conversations with others, no matter where you are, and get people to understand that what trauma-informed care is, or trauma-informed systems of care can be, and start. And actually, I won't go on because I just want to say that, and I want to thank you for the opportunity to be here and to see how so many folks are very much interested in this topic and gaining more knowledge about it. So thank you very much, everyone. Really appreciate it.
And I actually just wanted to echo one other thing that you said earlier, is to listen. We all need to listen better, even to those people that we disagree with, because if we don't try to understand where they're coming from, we're never going to help with this relationship. So thank you for bringing that out on it.
You're welcome.
Tracy, some thoughts?
I'll be super brief also, but I was just thinking one of my favorite phrases has always been, you can't have breakthroughs without having breakdowns. And I think we are in our culture and our world right now in this massive breakdown. And I think the opportunity for this change, because it's so desperately needed, has never been greater. So I would just say thank you, Drew and Allison, for hosting this and having more of these conversations where the collective can come together and the synergies can form, because the time is now.
That's right. I agree.
Liza, do you have final words, final thoughts?
Yeah, I keep it up. Recognize, like I said, I think we need to move away from a them and they and move to us in recognizing that this is a human condition. And so pick a human and interact differently. I will leave you with a to-do. One of my favorites is the 10 and 5 rule, that if you are within 10 feet of another human being, just acknowledge their presence to them. And if you're within 5 feet, actually open your mouth and say hi.
I love that. Thank you so much, Drew, for hosting this one, and thank you, Ane, Tracy, and Lisa. Thank you all for attending and for your wonderful comments. If you'd like to save the chat before we close this out, just go over to the chat and click on the 3 dots and then click save chat. And I'll just give you a moment to go ahead and do that now if you want to save these resources, including the websites for our 3 featured guests. And I invite you to join again for another Better Normal. The next one will be Tuesday. We'll be talking about our internal racial equity process at ACEs Connection. And you can find that and register for that by going to our homepage, acesconnection.com, and scrolling down to the right-hand side where it says webinars. And that's where you can register for our next event, which is Tuesday. And I hope to see you all there. And I hope you all have a wonderful weekend.
Thank you, everyone.
Thank you very much. Bye.